So good afternoon. I am Owen Sharp, Chief Executive of Prostate Cancer UK, and it's an absolute delight to be here to introduce our next speaker, who is giving the Prostate Cancer UK guest lecture. Just very quickly in 30 seconds, just to say on behalf of the charity how much we value our partnership with BAUS and how important the relationship we have with you is in terms of everything that we're trying to achieve as a charity and do a better job for men with and facing the prospect of prostate cancer. We couldn't do it without you as a clinical community. We absolutely rely on you as being a big part of our Men United movement. I will make a very unashamed and brief plea that if you haven't been and seen us on the stand in the exhibition hall, please do drop by. And I will have failed if you don't all leave this conference wearing one of our badges, our Men of Many. Really important part to have you as big advocates for us. I'm absolutely delighted to be introducing Professor Martin Sander, who is Chair of the Department of Urology at Emory University Medical School at Atlanta. Martin has a frighteningly impressive CV and has probably collected every big badge in terms of where he's worked at institutions such as Harvard, Beth Israel, Dana-Farber, and he came into all of that having been a prodigy of Patrick Walsh at Johns Hopkins, so I think you will all know even better than I how impressive a background that is. Far too many things in all that he has achieved to mention, but a couple of things is just to say that he is currently the principal investigator on a 3-centre study that's jointly funded by the National Cancer Institute and our sister charity, the Prostate Cancer Foundation in the United States, that is looking at the development of diagnostic urine tests, a really important piece of work. But probably most excitedly from my point of view, why it's a privilege to be introducing him, he is also, amongst all the other things he does, and I do not know how he has enough hours in the day to do it, he is chair of the global steering group of the Movember True North programme, which is a programme that we at Prostate Cancer UK are working with partner organisations brought together through Movember to really drive forward innovation through clinicians and patients working together to get to better experiences and better outcomes. And on that note, and within that background, I can't think of anybody that I would rather be introducing to give the keynote address on behalf of Prostate Cancer UK. Thank you, Martin.
Thank you very much. Thank you, Owen. Thank you very much. It's a real pleasure to be here. Quick flight from Atlanta to Manchester, so I enjoyed that, and this is certainly a tremendous meeting. Really quite an honor. I thought that I would talk about a couple of current issues for you today. Really 3 things. So we're going to talk about the Prostate Health Index. This is something that can improve upon some of the limitations of PSA testing as a means of early detection of prostate cancer. We'll talk a little bit about the prostate cancer RNA as a target for detection in post-DR urine, PCA3, as well as other tests coming down the pike in that arena. And then I'm going to spend some time talking about what can we do then for the patient who's been diagnosed with prostate cancer in terms of better incorporating patient-reported perspective in the initial care decision process. And in particular, I'm going to point out an area that I think has been hitherto somewhat underappreciated, which is the impact of obstructive lower urinary symptoms as a context for decision-making in prostate cancer care. Okay, so Prostate Health Index, many of you are familiar with this. It's been around for some time. I don't know the NHS position on it, but it's widely been studied, and it's been approved by the FDA in the United States. It is really a test that evaluates the -2 pro version of PSA. That's to say it's PSA before it's cleaved to its enzymatically active form. And it turns out that that form of PSA has a different expression pattern in cancer than in benign prostate, and we are awaiting coding policy, but initial work on Prostate Health Index in the pivotal trial, that was an international trial led by Bill Catalona, showed that it did improve over total PSA or percent-free PSA. However, those studies initially looked at a mix of patients who were coming for their initial prostate biopsy and patients who were coming for a repeat prostate biopsy. And in fact, if we look at the landscape of detection studies in prostate cancer in the past, if we go back 2012 and earlier, many of the cohorts mixed together those two populations, which are very different clinical settings. We know very well that the man who's already had a negative prostate biopsy once, the prospects for finding a significant cancer in that situation is much less than someone who's never had a prostate biopsy before is coming in for their initial elevated PSA evaluation. So what we did is we took the approach of asking how can PHI, the Prostate Health Index, work specifically in men who have not yet previously been evaluated for an abnormal PSA. And the goal then was, could we reduce unnecessary biopsy while retaining high sensitivity for predicting specifically Gleason 7 or higher prostate cancers? So lumping the Gleason 6 or lower together with non-malignant diagnosis as the endpoint. In this study, we enrolled 956 patients. 561 were the developmental cohort, and another 395 the validation group. The material serum was collected before prostate biopsy, and then the lab was blinded as to the results of the biopsy, and this was done through the NCI EDR Early Detection Research Network, which is a multi-site national program in the U.S. funded by the NIH to conduct these types of studies. Okay, so what do we find? A little bit of a busy slide, but the bottom line we're looking at here is indolent cancer or non-cancer, the distribution of PHI, higher PHI on the x-axis, lower PHI on this end, and then Gleason score 7 or worse. And what you see immediately is that patients with a low PHI do not have Gleason 7 or worse cancer. And it's a significant number of patients that fall into this category of PHI under 20. And in fact, as you'll see down the line, we found that the optimal cut point for PHI in this space was a PHI score of 24. So what was the impact here in the developmental cohort and in the validation cohort in terms of the impact on specificity? Okay. So first of all, between 20% to 30% of the men who came to biopsy were subsequently found to have a Gleason 7 or worse cancer. Pretty standard for the elevated PSA population that we see in the United States. Now, the ROC curve for PHI was better than that for percent-free PSA. That 0.8 is somewhat of a benchmark for things that will improve upon PSA. But I think most importantly, what we were interested in was, while retaining a high sensitivity for Gleason 7 or worse cancers, would we be able to improve upon the specificity? That's really how we're going to get around that problem of false positives. And what you see here in the developmental cohort with the PHI cut point of 24, specificity would be 35% as compared to 17% for PSA and 20% for percent-free PSA. And that improvement in specificity was validated in the subsequent validation cohort. What does this mean? Well, it's basically telling us that the PHI test can improve over PSA alone in terms of avoiding unnecessary biopsies in over 1/3 of cases while still retaining a high sensitivity for detecting the Gleason 7 cancers or Gleason 7 or worse. So that's an opportunity for the NHS. They're looking to save money so they can buy more robots. This is one way to save money. Do a second test after a PSA test to see who really needs a prostate biopsy. Definitely an area of opportunity. I'm sorry if the commissioner is not here anymore, but what about post-DR urine testing? Okay, another area where there's tremendous opportunity, both with the tests that are available today, but even more so with tests that'll be coming down the line. Well, the poster child for this is PCA3, or the, maybe not poster child, but prototype, which is also FDA approved. In the US, PCA3 is approved by the FDA to help discern men who are eligible or appropriate for repeat prostate biopsy. So we asked the question, could PCA3 be targeted, and how well does it work on initial biopsy? And in particular, we looked at combining PCA3 with urine testing for TMPRSS-ERG. TMPRSS-ERG, as most of you know, is a genetic mutation, a fusion event that brings the TMPRSS promoter. It's a prostate-specific promoter for a serine protease on chromosome 22. TMPRSS promoter is juxtaposed to the ERG transcription factor. ERG transcription factor is not normally expressed in the prostate. There's usually a 2.5 megabyte type of difference, distribution difference, length difference in the DNA between the TMPRSS gene and the ERG gene. What happens in 2/3 of prostate cancers, either a deletion event or a translocation event leads to ERG being expressed in prostate epithelium due to the presence of the TMPRSS promoter. So in this particular urine test, we are evaluating the presence of that particular mutation, which is present in 2/3 of prostate cancers. That is, by the way, the most common genetic mutation in any solid cancer of any type. So the study objectives here were to see if that combination of TERG and PCA3 could improve again around this paradigm of trying to detect Gleason 7 or worse cancers while not over-detecting Gleason 6 and reducing unnecessary biopsy for non-cancer diagnosis. We also looked at actually the potential healthcare costs of incorporating such a strategy into the algorithm of care. So here again, we had a developmental cohort and a validation cohort, multiple sites, over 1,000 patients overall, urine collected before prostate biopsy, and then analysis by a data center blinded to the details of the patient biopsy. So what do we see? First of all, what you see, no cancer up here, Gleason 6 cancers here, Gleason 7 cancer here, and right off the bat you see this trend shift with the no cancers in the setting of TMPRSS-ERG, less so in PCA3, a change as we go to a higher score. When there's no cancer, we don't see as many higher scores. When there's Gleason 7 or worse cancers, higher scores both of TMPRSS-ERG and PCA3. Because TMPRSS-ERG is only present in 2/3 of the cancers, as a standalone test, it's really not going to cut it. It's going to need to be combined with other tests. But it can be useful to improve on other tests in that strategy, or at least that's what we hypothesized. So what did we find? Here again, we were focused on achieving a higher specificity while retaining high sensitivity for Gleason 7 or worse cancers. And so that was the models that we looked at. We identified what the cut points would be, for example, here for PSA. What is the cut point for PSA that retains 95% sensitivity for Gleason 7 or worse cancer? That cut point in this cohort of 1,000 patients turned out to be 3.0. That validates the cohort as relevant to, for example, the ERSPEC trial cohort subjects. At that setting of that cut point, however, the specificity of PSA for Gleason 7 or worse cancers is only 18%. That's a lot of unnecessary biopsies. With the PCA3 and TMPRSS-ERG tests, that would improve the overall specificity to 39%. So again, an opportunity to significantly reduce the number of unnecessary biopsies by looking at testing, non-invasive testing, following a PSA in order to drive the decision of should a biopsy be done or not. So that is summarized in this slide. 43% of unnecessary biopsies would be eliminated in the cohort that we studied had that cut point for the urine tests been applied in the setting of the validation cohort. Now, a couple things. First, I'm going to point out the test does a better job, the urine tests do a better job on excluding patients who have no cancer than they do on excluding patients who have a low Gleason score. Only 11% of the Gleason 6 cancers would have not undergone the biopsy. And that's because the TMPRSS-ERG mutation is similarly distributed between Gleason score 6 cancers and Gleason score 7 or higher cancers. So there is an opportunity in terms of forthcoming urinary testing to focus on RNA markers that may be more specifically associated with Gleason 7 or higher and not present in the indolent setting of Gleason score 6. So that's just an opportunity that I want to point out. Now, what about the costs? So we look here not at the downstream costs related to life saved or the downstream costs of side effects. But looking just strictly at the actual hardwire costs of care, irrespective of the potential healthcare benefits of identifying cancers and saving patients' lives if we treat the right Gleason 7 or worse cancers. And so the way the models worked out, when we compare to the no screening paradigm, which is the U.S. Preventative Services Task Force perspective shared with the NHS that men should not undergo PSA screening. You know, the wisdom of that, I think, is questionable as a en masse strategy. I think we have to recognize that individualized decision-making is the way we want to go, not a one-size-fits-all strategies. But anyway, be that as it may, if we look at the one-size-fits-all strategy of no man should be screened, clearly that's the cheapest way to go, because then you have to pay for any health care costs. So that works out nicely for the accountants. However, ultimately, you do wind up bearing significant costs, particularly in younger men, if they're diagnosed with advanced disease later in their life due to the fact that early disease was not detected. Now, with PSA, the problem is there's too much overdiagnosis if you just drive treatment based on PSA. But what we found is if you add the urinary tests to the mix, and similar would be true for the PHI test, if you're able to drive up that specificity up to that 30 to 40% range and potentially higher, you start seeing a benefit even in the hardwire just cost of care, let alone the potential for saving lives, particularly in younger men, relative to not doing anything. Okay, so combining the urine tests can avoid unnecessary biopsy. Healthcare cost savings could be potentially realized. Okay, well that's fine. What about now you have the patient, he's been diagnosed with that Gleason 7 cancer. What do you do, right? And you've got a patient, they've got, you know, 63-year-old guy, and he's got a little ED, but his wife tells you, don't worry about that, you know, I really not interested in having sex with him, and we haven't had any in the last 3 years anyway. And you're trying to figure out with him, okay, which way to go? Surgery, radiation, maybe watchful waiting. He's in his mid-60s, what do we do? Well, I think one of the things that that is a real opportunity, both at baseline and in follow-up, is to look at the quality of life assessments and really move some of that into a practical and actionable way into that clinical decision-making forum. Right, and that's what I'm going to talk about next. And in particular, I'm going to focus a little bit on some new findings that we just submitted for publication and not yet published around the burden of lower urinary tract symptoms, obstructive lower urinary tract symptoms among men with newly diagnosed prostate cancer, and the impact on those symptoms of treatment. So this is really an analysis that we did of a cohort that we've been following for some time, the PCUK consortium cohort, over 1,000 men. The cohort was initially described in the New England Journal of Medicine a few years back, following their outcomes in sexual, urinary incontinence, urinary obstruction, bowel, rectal, and vitality domains. So that's the cohort that we turned to with this question. Previously in that cohort, we had published work showing how the baseline symptoms, for example, sexual functioning. I mean, ED is not just a yes or no, all or none phenomenon, right? It is really a gradient, as we all know. And so if you take and incorporate into your practice actually measuring that in some practical, realistic way, that really then begins to drive the opportunity to segregate the potential prospect for erection recovery after, say, prostatectomy as shown here. If you think in terms of age, if you think in terms of the severity of cancer by PSA, and then on the x-axis here, if you think in terms of the baseline functioning is really the driver for the recovery, irrespective, you know, even within the context of, say, all nerve-sparing surgery. Okay, so we chose to look at the question, well, what about this mix of incontinence and obstruction, these diametrically opposed urinary issues that we're dealing with our patients, and we recognize that there's a mix of these, more so the obstruction thing before treatment, a mix of the two depending on the type of treatment thereafter, and we really wanted to focus on kind of the combination of these two spectrums of urinary functioning, and that is very nicely captured by one question from the UCLA Prostate Cancer Cancer Index quality of life instrument, the overall urinary bother question. It's something along the lines of, how bothered are you by your urinary symptoms? Big problem, moderate problem, small problem, very little or no problem. It's a very robust. Now, the beauty of this item, this one question, it associates very closely with incontinence scores, and it also associates very closely with obstruction and irritative scores. So it provides an opportunity when you look at the data and when you see your patient to see how those two mix together and where they fall into place. And what we were really interested in doing is asking the question, what happens to men who already have LUTS? Walking into it. How important is the relief of that LUTS that they might experience after treatment for their prostate cancer, and how does that play out relative to their incontinence or other concerns? So the first thing we looked at is just simply, okay, what are the impact of treatment on medication use? Whether it's medication for LUTS beforehand or medication for anticholinergics or such alpha blockers beforehand, anticholinergics and others thereafter, or looking at procedures for urinary issues. And, as one might expect, we saw a drop-off in medication usage post-surgery as compared to pre, and not so much with the radiation. And of course, with the brachytherapy, most patients or half the patients are going to be on some kind of medication for irritative symptoms so lifelong. Okay, so we wanted to drill down then on what about the patient's overall bother with their urinary symptoms, and how does that break down based on where they are before their treatment. And so here we've got radical prostatectomy, external radiotherapy, brachytherapy. Now what we do here is we compare the pre-treatment overall urinary bother to the post-treatment steady state. The steady state we find really starts kicking in about 18 to 24 months. So the recovery process or the immediate initial impact process with either surgery or radiation is usually in the first 18 months. After 18 months, things tend to be relatively stable. So here we're looking pre-treatment to 24 months after treatment. Red are those patients who reported a worse state of affairs in terms of their overall urinary bother at 24 months. Compared to that same patient's status before treatment. And green are patients who reported an improvement. Their response to the overall urinary bother was either a major improvement, that would be a two-step change. Patient, say, big problem, comes back and says, now it's only a small problem. Or a patient with a moderate problem comes back and says, very small problem, or vice versa. And so what we found, I have to say that we were a little bit surprised. But now that I've started practicing this in my practice, I get it. But I think that I think we shortchange, even as urologists, the reality of the impact of the burden of LUTS on our patients, and in particular on our patients with prostate cancer. So if we look at patients who had no symptoms at baseline, as you might expect, more patients had worse bother 2 years later than beforehand because they had new incontinence and they didn't have problems beforehand anyway. But, it's that 11% major worsening. That's kind of in line with what we know from incontinence rates long term. 17% minor, and then, a few kind of, so, the minor changes, I think some of that can be regression around the mean, just changes in responses to questions. So that's why I think you see for a lot of the minor improvement or worsening, similar levels on the upside and downside. Now here's the patients who had moderate or severe LUTS based on the AUA symptom index prior to treatment. 2 years thereafter, substantial number, really significantly higher, that are reporting that overall they're actually better off. And what you see is 7% that are reporting major worsening as opposed to 28% major improvement. There's really a different kind of a conversation to have with that patient with LUTS. Yes, there might be some incontinence problems, but by 2 years or later out, those are likely to pale in comparison to the benefit you're going to see from not having to get up three times a night, or not having to stand there for 4 or 5 minutes to get your bladder emptied at the urinal. It was interesting that a less so but modest effect was seen with radiotherapy. And we haven't really drilled down as to whether this is the patients who have the combination of hormonal and radiotherapy or not. But there was at least some benefit there. It was a little bit more evenly spaced, though, between the improvement and the deterioration in that context. But I think what we had not expected is, the proportion of patients that were in this category. And it's a large proportion of patients that actually come in. They'll have that IPSS score of 15 or 18 or such. And we thought, well, let's drill down into this a little bit further, because if it's really 208 out of the 500 patients who are having prostatectomy that are in this category, well, within that 208, is there additional potential benefit? By the way, I just showed this slide. We validated that. What we found in our North American cohort, we validated it with a Spanish cohort from Montse-Ferrer. So we validated it internationally. So this is a real phenomenon, the notion of patients with LUTS beforehand reporting that they're better off rather than worse off in terms of their urinary domain. So, I think we really have to have it's a frame shift here. Prostate cancer treatment, localized prostate cancer treatment, is not only about making symptoms worse, causing symptoms that weren't there beforehand. So this is going to compound the comparative effectiveness analyses, because up to now, I guarantee you, they have only been unidirectional. I think the one group that has reported on this type of thing before was the SPCG4 study, the Scandinavian randomized trial of prostatectomy to watchful waiting, where in a cross-sectional survey many years after the randomization, they showed the burden of LUTS on patients who hadn't been treated. But if we look specifically at the additional question of what about patients who actually not only had LUTS, but had LUTS despite being on alpha blockers, there the effect becomes really quite dramatic, both for the surgical patients, less so, but also for the radiation patients, where men reporting moderate or worse problems, 37% beforehand to 0% at 2 years after treatment. So the guys who have LUTS, despite alpha blockers, they're really in a bad way. They need something done. Could a TERP accomplish the same thing? Well, probably, but it's not going to treat their Gleason 7 cancer. So baseline quality of life can facilitate your treatment decisions. The key component here in terms of the upfront evaluation is the IPSS. Most of you how many of you use the IPSS in your practice? Right? It's a great tool. Before you walk in the room, you know exactly what's going on with the patient. Shortens your conversation by 5 or 10 minutes. You can drill down right on what needs to be done or whether your medication has been effective. So too, then, I think we can do with these various domains after prostatectomy. What we did is we went back and realizing that we need to make these quality of life tools actionable at the point of care. So we have reformatted the EPIC questionnaire essentially to copy or mimic the format of the IPSS. So it's 16 items. It's 16 items on one page. It looks busy here, but when you print it out, it's very workable. Patients like it. It fits. It works. And each domain has 3 questions. And you can add up your questions, 0 to 12. 12 is max. They're doing bad. 0 is great. They're doing great. You've got incontinence. You've got urinary irritation obstruction, bowel issues, sexuality, and hormonal vitality concerns. You get it all on one page. We found this to be actually more useful in the post-treatment evaluation of seeing what we need to do for the patients than we do in the pre-treatment. This is available to everybody. It's been published a couple of years back. Peter Chang was the first author on it, Journal of Urology. The figure is right in the paper. You can just copy it out from the web and try it out. So in terms of emerging paradigms, I guess what we've talked about today is a couple of approaches in terms of how to make PSA testing better. Let's get beyond the one-size-fits-all. Yeah, PSA for everybody isn't good. We overdid that in the U.S. for the last 20 years. But on the other hand, ostrich head in the sand, that's not very good either. So we can really utilize tests like this to find a workable middle ground and save the NHS some money. Patient-reported symptoms, quality of life. I think the time to bring the quality of life and patient-centered reality in prostate cancer care is here. I think that the EPIC CP instrument, EPIC for clinical practice, hopefully is a tool that perhaps some of you will find useful, like you do the IPSS, as a means to make that possible. Make your practice more efficient and actually put you on the same page with your patient because of their ability to address issues on that questionnaire that may be a little bit harder to elicit in the conversation, depending on the patient. So I want to thank you. I want to acknowledge our various collaborators listed here who participated in various aspects of either the quality of life or the early detection studies. And I certainly want to acknowledge our funding, which I think importantly has been largely from the NIH and from Movember for these various works. So thank you. Any questions? Speechless. Okay. Thank you very much.